Welcome to this morning's webinar on pandemics and universal health coverage. We are pleased to welcome participants on all platforms and are happy you could join us this morning. This seminar is hosted by the Research Department of the Eastern Caribbean Central Bank as part of the bank's continued engagement during this difficult period. The ongoing COVID-19 pandemic has had severe impacts on the lives and livelihoods of people worldwide. Moreover, it has exposed in the ECCU and elsewhere gaps in health infrastructure, health information systems, and deficiencies in frameworks for design and implementation of public health policy. These gaps and deficiencies have implications for the delivery of health services and the achievement of Goal 3 of the Sustainable Development Goals. Goal 3 of the SDGs aims to improve access to healthcare to ensure healthy lives and promote well-being at all ages. Before the pandemic, member countries of the Eastern Caribbean Currency Union were at varied stages of preparation of national health insurance initiatives aimed at ensuring universal health coverage consistent with commitments made in 2015 under the UN 2030 Agenda for Sustainable Development. The disruptions in the delivery of health services brought about by COVID-19 and the fiscal burden of increased resources to healthcare and social support systems will undoubtedly result in a reversal of some of the progress to date in the delivery of health services. This webinar aims to highlight the impacts of the pandemic, the implications for the design of public health policy, and approaches to the delivery of universal health coverage. A word about the panelists. This morning, we bring you 3 accomplished panelists. First up will be Dr. Stanley Lalter, who is currently a research fellow at the Center for Health Economics at the University of the West Indies, St. Augustine. He is a graduate of UWI St. Augustine, University of Cambridge, York University, and University of London. He is a member of the Caribbean Commission of Health and Development, established by PAHO and CARICOM in 2005, with the objective of charting a roadmap for health policy and programs in the Caribbean. He is co-editor of the very popular book, Caribbean Economic Development, that many graduates of the University of the West Indies would have utilized, the first independence generation. Dr. Lalter's special interests and publications are in universal health coverage, health financing, social health insurance, chronic diseases, and pharmacoeconomics. He is well placed to assist us in discussing these issues this morning. Dr. Kester J. Ned is the founder, chairman, and CEO of the JIPA Network, LLC, a global network of healthcare providers. Dr. Ned has devoted a significant portion of his career to the development of models for affordable healthcare by organizing companies and systems to deliver healthcare utilizing managed healthcare, value-based principles, and modern information technology. He has served as president and founder of Physician Care Network, a Medicare managed care network. Dr. Kester Ned's career in medicine spans 45 years as a practicing neurologist in the United States, and he has held faculty positions as an associate professor of neurology and head of the U.S. Sports Concussion Clinic at the University of Miami. Dr. Anton Cumberbatch is currently technical advisor to the Center for Health Economics at UWI St. Augustine. He has been a key member of the health economics team on national health insurance initiatives in St. Vincent and the Grenadines, Grenada, and Jamaica. He continues to be an active contributor to health sector reform work at the Health Economics Unit. Dr. Cumberbatch held the position of Chief Medical Officer of Trinidad and Tobago over the period 2008 to 2011, and the post of County Medical Officer of Health for St. George East in Trinidad over the period 1995 to 2008 and 1991 to 1992. Dr. Cumberbatch has been dedicated to the improvement of public health in the Caribbean and therefore has been intimately involved in health sector reform initiatives in his home country, Trinidad and Tobago. He was appointed Chief Executive Officer Designate of the National Health Insurance Scheme in Trinidad and Tobago and head of the government counterpart team of consultants. I am your humble servant, Tracy Polius, Chief Director Policy at the Eastern Caribbean Central Bank and moderator for this morning's proceedings. Some notes on housekeeping. Each of our panelists will deliver a presentation for approximately 15 minutes. Dr. Lalta will speak to the health sector challenges that have emerged as a result of COVID-19 and the implications for health service delivery in the ECCU. He will be immediately followed by Dr. Cumberbatch, who will highlight the implications of the pandemic for public health policy and present some recommendations for addressing those challenges. Dr. Ned will speak to approaches to the development of models for affordable healthcare and national health insurance with emphasis to ECCU member countries. The presentations will be followed by questions from the audience. Questions will be taken from batches of 3 to 5, and the panelists will be given an opportunity to address them. Given the nature of this event, the host will mute all microphones, and participants will be allowed to unmute their microphones during the question and answer segment. We immediately start this morning's proceedings by inviting Dr. Lalta to commence his presentation.
Thank you very much, Madam Chairperson, panelists and participants. A very optimistic good morning to everyone, knowing that we are in a rather dismal period with a pandemic staring us and having to be confronted. This is a joint presentation that will be done by myself and followed immediately by Dr. Cumberbatch. I've borrowed a term that has been used by the governor of the ECCB, navigating, because I do think that what we are entering into is how do we pilot our countries through this unprecedented crisis, through this, some are describing it as an existential threat, some are describing it as an invisible enemy. How do we pilot our countries through this? And what is the role of universal health coverage in this process? The presentation is organized along these lines. Immediately following this, I'm going to show a couple of slides which give us a quick idea. What is the status of the epidemic? What are some of the economic and social impacts? Without getting into too much detail on these, because I do think that there's enough literature floating around which can give us a much fuller appreciation of these. Just to pull out some of the highlights for these is what I will be doing. I look at some of the key lessons of experience in pulling out from COVID, what does this mean for health sustainable development? The chairperson has already mentioned the role of the SDGs developed by the UN and adopted by all our countries. But I also want to touch on what does this mean for the cultural framework of our countries, our cultural values. What does it mean for individual rights, civil liberties, freedom, social responsibility, and what is the crucial role of leadership in this process?
Dr. Lalta, can you speak up a little, speak a little louder?
Okay, thank you very much, Tracy. I will try so. Is this any better?
Sure, it's better.
Okay, thank you. The third part of the presentation will really look at some of the key aspects of universal health coverage. 3 dimensions, what we want to look at in terms of population coverage, so that no one is left behind, the crucial matter of quality of care, and then health financing, which will then float very easily into what Dr. Ned will be looking at in terms of NHI in Grenada, and in the OECS countries. The fourth part of the presentation is where Dr. Cumberbatch comes in, because he's going to look at the critical implications of the pandemics of universal coverage and how do small countries respond? How do we adjust? How do we confront? How do we navigate these challenges? And then we end up with a few pointers on coping with COVID and what our exit strategy may look like. Just some very quick aspects about the epidemiological burden so that we can put all of this into perspective. December 2019 seemed a very long way from now, but actually this is when it all started. And initially in that province of Wuhan, it was felt that this was a very localized outbreak. Very soon, because of globalization, this spread. So that now we are in August, we are nearly 24 million cases around the world, 814,000 confirmed deaths in all continents, the Americas, Europe, Asia, Africa. And this is only the confirmed version. There may be other cases which have not been counted and which have not been confirmed. What is still unknown, because this is a very strange pandemic to some extent, how it started, what are the symptoms, what's the treatment, is the vaccine going to work, is it going to work for a long period, what is the extent or the length of immunity? These are still unknowns, which are the subject of the intensive treatment protocols and the testing of the vaccines which have been undertaken. Who's affected? Well, very early on, it was felt that this was a disease or this was a condition that was only going to affect elderly persons and those with pre-existing conditions. This has been proven to be wrong. They are still the most vulnerable, but now look at what's happening to frontline workers. Look at what's happening to persons in what may be called deprived communities, where the social determinants of health are very crucial. Look at what's happening with children, what's happening with the younger population. So this is a disease which is now crossing age barriers, which is crossing income boundaries, it is crossing geographic boundaries. What has this led to? In many countries, the overwhelming of facilities, of staff, decisions have to be made on prioritization of patients. Who is going to get tested? Who is going to get treated? Who's going to get that ventilator? And we expect soon, when the vaccine comes on, who is going to get priority for the vaccine? To some extent, and PAHO and the WHO has brought this out, it has led to a certain amount of deprioritization of other diseases. For example, some non-communicable diseases, HIV, immunization for other diseases seem to have fallen by the wayside in some countries. It has also brought about a certain amount of competition for the vaccine, and I'll touch on this a bit later, where you now have about 170 candidate vaccines which are being developed. And it has also led to a certain amount of what we can call vaccine nationalism. I should be first. Already countries like the US, the UK, India have cornered the production facilities to say that we must get priority. Where's the role? What's the role of the WHO? What's the role of internationalism? The role of small countries in all of this, and who will get the vaccine first? And all of us are being asked to share this responsibility of flattening the curve. Social determinants, as we all know, because this is what affects a lot of persons. Not everyone has formal jobs. Not everyone is well educated. Not everyone is well housed. And where you have differences in all of these, then you are going to have social differences. And this is what is playing out very much in terms of who is affected more, who is dying more from the disease. How do we slow down the pandemic? And this is a very popular graph that has been presented in several places. How does an epidemic unfold? And what's the impact on the population? If you look at the dotted line really represents your healthcare system capacity. but can you cope with? The blue line showing the very steep curve at the top. If you allow the disease to run rampant without some kind of control, if you allow it to run through the population, then you have what is called uncontrolled transmission. It floods the country, overwhelm your health facilities. How many persons die in that process? Uncountable. If, however, you can control the disease to some extent, and this is where social responsibility, this is where regulations, which is where personal controls and personal responsibility become very crucial. If you can manage to do that, then you can contain the disease to some extent within the capabilities of your health system. But if you don't, then you have the blue curve facing you. How do we flatten the curve? And then to some extent, what we're finding is that there's no single curve. We talk about the first phase, we talk about second phase, there may be a third phase. So it's not just one single curve that we are looking at. How do we flatten the curves? Infection rate, fatality rate, reproduction rate, treatment rate, testing rate, all of these have to be considered when we look at the epidemic. Economic dimensions, and I think that the international organizations, the IMF, the World Bank, they've had to change their assessments. In January, the assessment as to what the impact is going to look like, and it was still felt that the world economy was going to grow by about 3 to 4%. In March, this had changed a bit. In June, this had changed even more, so that you find that now the IMF is predicting that there will be a 5% decline in global output. That's an average. Different countries are going to be affected differently. Unemployment, severe. In fact, ECCLAC in this July 2020 document indicated that because of the loss of global output in the Latin American and Caribbean countries, we can very well look upon all the gains that we would have made from 2010. Look at this as a lost decade. In fact, when you look at the sectors which have been affected, then you can begin to see that all countries, given the globalization of trade, of travel, of markets, are affected. But somehow, who's growing? The online businesses, the takeaway places and points are growing. Can everyone see the slides? I mean, I'm just getting a little note which tells me that we're still only seeing the first slide. Tracy, chairperson, can you just verify for me if the slides are running as I have them here? Or if this first slide
Yes,
is still
Dr.
running?
Lalter. Your slides are running now.
Okay, thank you. All right. For countries and the macroeconomic indicators, what's happening to fiscal deficits, fiscal balances, debt, balance of payments, foreign exchange earnings, foreign exchange reserves, poverty, are all some of the macro aggregates which have been severely affected. In fact, the ECCU governor is now speaking about what can be called a U-shaped recovery. But I can also think about some other shapes which we can consider. We can also consider a V. We can also consider a J. We can consider an L, although no one wants to go in that direction. We can consider a W shape. Hopefully it is a U shape, but the depth and the length of that trough is what is going to be the important consideration. Social impact of the virus. We are now speaking about a new normal. Emergency, shutdown, lockdown, restrictions on schools, church activities, sports, cultural events. daily life, visiting elderly relatives. Persons want to go to funerals who may be caught abroad and can't return home. I mean, the social impact has been severe. But more than that, what it has meant is in terms of the stigma and discrimination of patients, and also of health and frontline workers. Bear in mind that health and frontline workers, more than 1,000 have died. Even in the Caribbean countries, many of them have come down with the condition and they now have to be quarantined. What's the extent of our protective safety net for the unemployed, the poor? Countries have tried to put together packages to assist persons, but for how long can these packages run? And then that's for only persons in your database. What about persons who are not on the database, especially those working in the informal sector? What about persons who may be what can be called undocumented persons, where the certainty of hunger has to be matched with what we call the lottery of the virus? So people go out and people do things quite contrary to what you may want to see happening in terms of the regulations and the lockdown. Just a quick slide to give you an idea what's happening in OECS countries. So far, generally, the cases have been kept into double digits, and the mortality or the fatality has been kept in single digits, mostly zeros. Guadeloupe, Martinique, our very close neighbors, some triple figures which you can look at, and in other Caribbean countries, Trinidad, Guyana, Bahamas, Suriname, Jamaica, for example, we're now running into four figures in terms of the cumulative number of cases. Now, in fact, the language is changing, not from so much the cumulative cases, but the active cases and the number of persons who have recovered. So this is a very important distinction which we need to be making. What does all of this mean? How should we view health? To a very large extent in many of our countries, we saw health as an expenditure. Well, really, it is an investment. It is investment in human capital, it is investment in social capital, because if we do not have a healthy environment, then it means that other sectors, other investments are going to crumble. In fact, it is health which gives us the freedom to achieve sustainable development on an individual level, at a country level. It is a foundation, it is a freedom, it is a flexibility which good health brings to the population. Now more and more we are realizing the importance of what is called public goods and public health goods. And this is something which Dr. Cumberbatch will touch more on in his presentation. Economic theory tells us as public goods generally are non-rival and non-excludable. Well, think about public health goods. Surveillance, disease control, sanitation, health education, all of these are imperatives which must be in place if we are going to manage this as well as other pandemics which may be coming up. International health regulations, and Dr. Cumberbatch will again touch on some of this, and this is a crucial aspect of our linkage with the international community. In fact, WHO has been very strong on this, that if all countries were following all the considerations and all the capacities which are required in the international health regulations, then probably we may not be at the stage where we are now. In 2019, there was this assessment which was done showing how countries are trying to put together their response capability to deal with pandemics. And in a way, the global score, 40 out of 100, meant altogether that national health security or preparedness to deal with pandemics is fundamentally weak around the world. And no country is fully prepared for pandemics and epidemics. Every country has important gaps to fill. And you can take a look at where some of the Caribbean countries are located in terms of their scores. Strangely, the US and the UK ranked number 1 and number 2, but I don't think that that is going to hold very much more. More recently, you have another index that has been coming around, and this is the one which has been prepared by Oxford University, what is called a government response tracker. And we can take a look at those and see where countries are in terms of 17 indicators pertaining to health, economic preparedness, social preparedness, and an overall preparedness index. Responsibilities for the state, responsibilities for individuals. This is a very crucial part of the whole process because we seem to think that government can manage all of this. Government on its own cannot. In the absence of a vaccine, in the absence of treatments, which can be magic bullets, solving the problem immediately, is very much left to individual responsibility. And we've defined this role of the state: educate, communicate, to test, to trace, to counsel, to isolate, to treat, to legislate, to enforce, to vaccinate, and the role of individuals. The role of individuals bring us to a very crucial point about what does it mean for rights, human rights, civil liberties, freedoms, as against social responsibility. You still have many persons who are not following the regulations. In fact, regulations are seen more as suggestions rather than obligations. Anti-maskers, anti-vaxxers, young who are invincible, those who are denying, the skeptics, those who think that's a conspiracy theory. Blame 5G, blame Bill Gates, blame some other causes. And then the fatalists among us who think that, well, you must die of something. Battling this global infodemic or the fake news is a crucial part of this. And this is where the right to private liberty now runs into the social responsibility dimension. How do we balance this is what we're facing. It is also a test of leadership, political leadership, medical leadership, business, civil society, religious organizations, social media leadership in the whole process. Because if we get this wrong, if the leaders don't know the way, show the way, or go the way, then it makes a mess out of what social responsibility is going to look like. Okay, a very quick look at universal coverage and all of this as part of sustainability. What does this all mean? Battling the pandemic, what does it mean for universal coverage? Well, in a way, universal coverage has a few critical dimensions. It says that you should have barrier-free access to a defined package of services, delivered efficiency, quality standards, adequately financed, based on equity and ability to pay. It also requires a multi-sectoral approach so that we can address the social determinants. 3 dimensions shown in this cube. We can look at population coverage, services which are covered, financial protection on the 3rd arm. Crucial in all of this in terms of we need to do the systematic evaluation. We think that because we have a public health system, there's coverage across the population. This may not be so. Do we have adequate coverage across age differences, gender, income, education, social class, disability, language, geographic distance? If we can do that evaluation, then we can begin to say that there's adequate coverage for health interventions for the total population. But if we haven't done that, then just claiming that we have a public health system does not meet the goal of total population coverage. Health quality. We may have services being delivered, but are they of adequate quality? Public sector, private sector, quality of our health professionals, products, supplies coming into the country, medications, facilities, are they licensed, pharmacies, labs? Can any lab do COVID test? Or do we have quality dimensions for these? Quality of health services altogether. And then the 3rd dimension of this is really the financing side. The financing side, what are some of the crucial lessons coming out from consideration of health financing around the world. We must have compulsory systems. Contributions must be fair. In a way, this graph gives us the critical insights into how we should organize our health financing systems. Contribute according to your ability, but you get access to care or you utilize care according to your risk levels. So equal incomes person, my first dimension, low risk, high risk, equal incomes, so the contribution is the same. And that's why the size of the arrows are the same on the contribution side. But when it comes to utilization or accessing services, then they access different levels because high risk will utilize more, low risk less, and so the size of my arrows are different. Or if you look at the second half of the diagram, equal risk persons, but one is low income, one is high income. If you contribute according to your ability, low income contribute a smaller amount, smaller arrow. High income contribute a larger amount. But because they're equal risk when it comes to utilization, they utilize approximately the same amount of services, and that's why the size of the arrows are like that. This is what you're looking for. From each according to ability to contribute, to each according to risk level, your need for care. If we can organize our systems on that basis, which is what health insurance, national health insurance tries to do, then we can take us very close to universal health coverage. Across the Caribbean, and Dr. Cumberbatch will touch on this much more. Across the Caribbean, we sometimes go with the impression when we speak about universal coverage that government must provide everything and government must finance everything. This is not so. There's some critical functions and services for government to provide. But because we also have strong and capable private health facilities, how do we bring them on board? And this is where the financing system, this is where your IT system, and this is where your quality of care dimensions will be the critical linkages between what you want to do with the public system, the private health system, because no single system can manage all the problems of the health or the health of the population or cover the cost of all of these. In the Caribbean, OECS countries, this is where most countries are. Antigua, for example, has moved very far ahead. Since 1978, Antigua has an operational medical benefit scheme. It's now been reviewed for full coverage. Virgin Islands has a universal coverage plan since 2016. Martinique, Guadeloupe, of course, they're part of the French system and they have their plans in place. Other countries are putting plans, preparations have been undertaken for full NHI. I want to draw a distinction. Don't only think that NHI means national health insurance. National health insurance is a critical financial aspect, but it is not the totality of universal health coverage. What does all of this mean then? Managing the pandemic, navigating pandemic, navigating universal coverage in small countries. And this is why I will turn it to Dr. Cumberbatch to continue the presentation. Dr. Cumberbatch.
Thank you very much, Dr. Lalta, and good morning to everyone. I would want to take a look at that slide that Dr. Lalta has put up, the proposed pattern of health provision and finance in the Caribbean. But before I do that, I would like to, from a public health point of view, because I'm a public health person, remind the audience of some things. The first thing is that this present pandemic was not an unexpected event. WHO PAHO has been saying for the last 10 to 15 years as a public health professional, I am aware of this, that we are expecting infectious diseases, new and emerging ones, and the return of some of those that have been there before. And they've been putting it across the globe, but it seemed that their exhortations to countries were not really taken on board. So this is not an unexpected event. The other thing I would like to make a point as we're talking about pandemics and small island states. And if you remember Dr. Lalta making mention at the start of his presentation of a number of epidemics that impacted upon us, the H1N1, the Zika, and those things to a small island state come like a pandemic. So we must remember that it is not just because they describe that it is a pandemic, that the impact of an infectious disease outbreak can be very dramatic and can have far-reaching consequences for small island states, especially states that are tourist dependent. So that's the first point. The other point I want to make is the question of universal health coverage. One of the things we must remember in a health system structure, and this is from a global point of view, health system structure, they are built upon a solid base of public health. If you don't have a solid base of public health, it does not matter how many hospitals, doctors, nurses that you have and what technology you have. What a pandemic shows you, it will overwhelm it and make all of it virtually useless because of the numbers of cases. And this is a very important point. We keep saying it, and for small island states, this is actually a critical thing to understand. We must make an investment with universal health coverage. Universal health coverage for small island states does not start with clinical services. I want to repeat that. It does not start with clinical services, nor does it end up with hospital services. Universal coverage starts at the base, meaning safe water, safe food, safe borders. And this is something the financial agencies need to understand. We get it just up. So having said that, I would now refer back to the slide where you see the proposed, the health systems that we were talking about, the slide, the proposed pattern of health provision, financing and services, that one. What you have there is on the left of the slide, public health, and the health providers are public health agencies, then the ambulatory, outpatient, inpatient. What it says to you there that health systems are built on that kind of structure. Public health, it's financed by, you see, taxes. Yes, NHI, no. This is the critical foundation of any healthcare system. So the universal coverage starts with that. And if you notice, it is funded by taxation. And if you get the coverage right, then the baseline is correct. The ambulatory part, the outpatient, which can be public or private, or NGO, the inpatient, public or private, and those two things are normally where you get the question of national health insurance. And you can get combinations of financing from public or private to cover that. So the point is being made here that the financing of care and the spread of the universal coverage is really interlinked between government financing and also financing from social health insurance or national health insurance and private sector financing. Next slide, Stanley. I think we need to go one step forward. Right. For a small island state, we have some issues with respect to how you approach these things. One, you will see that we are open and we're externally dependent. We are resource constrained. Now, that resource constraint, because we do not have capacity of hospitals, doctors, we do not have depth of technology, it means that our response to things like pandemics or challenges has to be early warning and prevention and early intervention. We cannot tell ourselves, like a major country, that we will have the hospital capacity or the technical capacity of all these labs and whatever else that they have, including the ventilators, to respond. So therefore, the collaboration of small island states together, early warning, early intervention is our solution. The other thing that is very important is to ensure that the health staff, the protective equipment that we may have, because there's something that we need to understand about pandemics and infectious diseases. The baseline equipment is fairly the same in terms of what we call PPEs. This is the personal protective equipment. So whatever you have as an infectious disease. Now, what it means is this: for our small island states, we must make sure that all our healthcare professionals have the ability to respond with that type of training and also what people are now calling the parallel healthcare system. Now, even though you have to have the parallel healthcare system, which says you can have your parallel healthcare system dealing with infectious disease, while the clinical services go on to some extent untouched by the infectious disease, a small island state has a limitation of that because of the sheer numbers. So therefore, our staff, even though that they may be working in the part of the healthcare system that is not impacted by the immediate infectious disease, they must be able to cross over and assist by having them being trained in PPEs and all the other things that we need to do for infectious diseases. There are some issues here with respect to the PPEs and the small island states. I'm going to make a little controversial statement here. As a small island state, we may need to look into the future in terms of our research to see if it is possible that we can and I'm careful with my words here, re-sterilize PPEs that are supposed to be there for single use, to have them function in a reusable form. Because it's either that or we ourselves in the small island states make PPEs. Because what we have learned in these epidemics and these pandemics is that the resources that you are depending on from the larger countries will no longer come to you when you have a pandemic. So we have to respond by developing our own PPEs for our own selves, not only just for the pandemic, for all infectious diseases. And the question of re-sterilization and reuse as a new initiative needs to come on board. Next slide, Stanley. The essence of the thing is what we want to make sure that we also understand, especially in this pandemic, in the situation of the Caribbean. The pandemic is an acute infectious situation. We have in the Caribbean a chronic disease pandemic also going on in terms of diabetes and hypertension. So what you're going to get is the impact of this acute infectious pandemic, and we are seeing, based on the reports that we're getting from the global response and the global impacts, is that this particular infectious disease has chronic disease implications in that people are having issues with morbidity long after the acute infection has passed. And we also now realize that the impact of this pandemic on chronic disease is deadly and disastrous. What does it mean for the Caribbean, who has a chronic disease epidemic going on? It means that when this acute epidemic is over, we will see the impact of the epidemic on our chronic disease patients, maybe for years to come. What is the implication? The implication is this, and this is where the universal health coverage or the clinical impact can take place. If we provide the services through universal coverage at the primary care level to control the diabetics and hypertensive, because what we know for this pandemic is that patients who have been properly controlled, the diabetes, the hypertension, the obesity, and prevention from strokes, they get less morbidity and mortality with the impact of the acute COVID. So what it is saying to us, universal healthcare coverage at the clinical level, impacting on our primary care services for all our diabetics, hypertensives, the people who have the risk of strokes, and obesity in children. If we were to concentrate on that using our universal healthcare coverage at the primary care level, it will have a very positive effect on the COVID complications that will persist with us after the acute situation. The other point I would make is the linkage across territories. The way that we can handle this is by working collaboratively across territories. Very, very important. We must collaborate, whether it is with the CARFOR, whether it's the CARICOM, whether it's with the PAHO, and share our best practices, our early warnings, and also for even the vaccinations to come using the revolving fund. So collaboration is what is going to give us the protection borders, and collaboration not only among ourselves, but collaboration with the major countries. My last little slide here, my last statement is for us to understand something. I know that COVID-19 has shaken up the world, but we have been down this road before. Maybe not with the kind of economic impact that is going on, but we have survived many, many types of infectious disease challenges. And one of the points that is being made, and people seem not to take it on board, when the statement is saying, well, you have to learn to live with the COVID-19. And it seems to be a shocking statement. But if you look at what has happened in the past, we have lived with polio, we have lived with measles, we have lived with yellow fever, we have lived with tuberculosis, we have lived with HIV/AIDS, and we have lived with all of these things. And we have learned to do it with common sense and logic. In a pandemic, the behavior of the public is as important as the behavior with the doctors and the protocols. And with that statement, I would like to turn it back over to Dr. Lalta to wrap up our presentation.
Thank you very much, Dr. Kamawach. Just 2 points in closing, and the slides will be available to participants. Firstly, to borrow the words of the ECCB governor, we must adopt a growth mindset, even as we tackle the crisis. There's a health crisis, an economic crisis, a social crisis, but we must have a growth mindset and emerge stronger and more resilient. So we have to accept a certain level of risk as we adjust, we move ahead. We cannot lock down indefinitely. So opening up with stringent disease control priorities and protocols is the key. Second major point in all of this is that we keep speaking about the new normal, but let's be very clear. This new normal does not mean that that's the end of the pandemic. It's not a post-pandemic world we are looking at. We have to look at the pandemic-prone environment, because the indications are there'll be further pandemics that we have to contend with. 20th century, the 21st century, the 19th century, we can go back in time. We haven't solved all of these problems. Yes, this is a category 5+ health disaster, but it doesn't mean that that's the end of all disasters like this. So pandemic prone environment, and this is where the whole matter of surveillance, protection, public health becomes very crucial. Our new normal in the Caribbean then cannot just be going back to what we had before. How do we become more socially equitable? What do we do about our economies that become much more diverse rather than dependent upon one single sector? How do we take on board the whole matter of environmental sustainability so that when we begin to talk about the future, this particular pandemic should give us the opportunity to really rethink what is this new normal in the future going to look like, and how can we make it more equitable, more diverse, more sustainable from an environmental point of view. Managing all of these changes for the new normal will require what we call the leadership, partnerships, and more we will realize people have to be empowered. Knowledge, capability, that is what is going to lead us into the new normal and into the future, which we will all want to be part of. Thank you very much.
For this very, very interesting and I would say presentation that is filled with information for all of us to digest. But before we move on to Dr. Ned, Dr. Cumberbatch raised a very important issue, which is that universal health coverage must start at the base, and it must start with issues related to security of our borders and food, issues related to the quality and security of our food. And this segues nicely into the next digital dialogue that the ECCB is going to host. This digital dialogue is titled Pandemic and Food Security, and it will be held on Thursday, 10 September 2020 at 8 p.m. During that dialogue, the governor will convene a panel that includes the Honorable Sabota Caesar, Minister of Agriculture in the government of St. Vincent and the Grenadines. And that digital dialogue will tackle the issue of food security, access to safe and nutritious food. So I just thought that I would inform participants about this as a related dialogue that the ECCB and related engagement that the ECCB will host. This will be hosted by the governor on September 10th, 2020 at 8 p.m. We will now move on to the presentation by Dr. Ned, who will speak to us a little bit about approaches to universal coverage and access to healthcare, affordable healthcare. So without further ado, we ask Dr. Ned to start his presentation.
Okay, good morning, everyone. I'm going to share the slides at this point so we can get started. Let's do share. First, could everyone see my slides? I just
yes,
hope,
we can.
Okay, and I'm able to advance, right? It's advancing properly?
Yes.
Okay.
Yes, Dr. Ned.
Okay, thanks. So good morning, everyone. I really appreciate the opportunity to present to the Eastern Caribbean Central Bank Research Initiative and the listeners or the persons participating in the webinar. So thanks all. First, I want to thank the unit at the University of the West Indies for the tremendous work that they have done in the Caribbean in analyzing the healthcare systems, and also the work they've done in Grenada in doing the initial research for the development of the National Health Insurance Initiative. Certainly they've done this in other Caribbean nations, and we have worked alongside them in the past, utilizing their data and the work they've done. So we are fortunate in the Caribbean to have such an organization to represent us in this field. And thank you, Dr. Lanto and company. Thank you. So today I'm going to focus on the issue of universal healthcare coverage in the context of the pandemic, and also in the context of what we're doing in Grenada to develop national health insurance. A little disclaimer, I just want to let everyone know that this is a model in progress and still being reviewed by the government of Grenada and the people of Grenada, and a committee, NHI committee, that's working with us. So first I'll start by asking this whole concept of universal care and universal access. This age-old discussion, is healthcare a right or healthcare a privilege? We in the Caribbean believe that healthcare is a right. For some reason, many developed nations, including the United States, believes healthcare is a privilege. But when you think of something being a right must have certain characteristics. It must be, first, I call it the 3 A's. It must be available, must be accessible. Well, you can have something available, but some people can't get access to it. So access and availability are 2 different issues. And the 3rd A is that it must be affordable. So in a way, we have to ask ourselves as Caribbean nations, is healthcare truly a right based on these concepts? Now, I was particularly impressed with the presentations prior in addressing this whole issue of healthcare as an asset as compared to healthcare being a liability. When we think of healthcare world over, we view it as a cost. It's a cost in our budgets. It's a cost for the government. It's a cost for people. But we don't see, many times we don't see healthcare as an asset, as an economic driver, as it is. And so one of the challenges we have in the region is that a missing factor that drives healthcare as an asset is the stakeholder consolidation, the stakeholder participation. That's a clear missing factor in this whole discussion of national health insurance. And so as a result, when we focus on the development of Grenada's brand of healthcare or potential brand, we look at it from the concept of stakeholder interest and participation. One of the challenges we've seen in trying to bring forth a national health insurance initiative is that the stakeholders have very conflicting needs. And some of them are actually contrary to the others. And that creates a sense of conflict and challenging. So for example, an insurance company's role is to run a healthy plan with a positive return for the investors. While a physician or a hospital's role is to be able to be adequately compensated for what they do and also to provide quality healthcare. So on one hand, you have a group that's trying to conserve resources, and the other hand, you have one group that's trying to spend resources. So that makes it rather difficult, and in terms of those conflicts, or how stakeholders view national health insurance or health coverage as a whole. Cheryl Yeo said, the best way to minimize disagreement is to make sure that all the stakeholders are in the room. What that really means is that if we have all the stakeholders joined together in some way, you have something called the power of numbers. When we look at the Eastern Caribbean as a whole, each territory is doing their own, they're doing their own healthcare systems. When you look at banking as an institution in the region, the Eastern, and I have to applaud the organization which is sponsoring for facilitating this organization of the Eastern Caribbean currency throughout the Caribbean in a way that you have the power of numbers. You have a strong currency as a result of collaboration. And if we can do this in banking, why shouldn't we do this in healthcare? The challenge of globalization has made healthcare a commodity. When I say a commodity, and most of us don't think healthcare as a commodity, I said this once, and a consumer of healthcare said to me, we can't look at healthcare as a commodity. Healthcare is a profession. Healthcare is a service. And I do agree with all of those descriptions, but in today's world, people are shopping for healthcare based on the following characteristics. They're shopping based on price. These are the characteristics of commodities. They're shopping for healthcare based on how accessible it is, what quality you have, and certainly certain laws of economics are beginning to apply, what we call the laws of supply and demand. In the past, in healthcare, you could have a lot of service, but yet the price goes up. And in many cases, when you have a lot in terms of supplies, then of course you have less demand. And so the prices generally come down. Until recently, those economic models weren't applicable in healthcare. And in particularly in systems in the Caribbean that's based on colonial models, we're not able to price healthcare according to real economic principles. So clearly, one of the stagnating factors of making healthcare a commodity in the region is to apply the principles of worldwide economics of supply and demand. That's an important driver of the service. We have a demand for services in the Caribbean, but clearly we don't have a lot of the supply. So issues that has made healthcare global in its reach. So in fact, if you look at television, if you look at social media today, there is a degree of transparency that's going on in healthcare. You can go online and look up the statistics of a provider based on the comments of the patients they see. You can look at forums and you could review a procedure as to how effective it is. I mean, all that information is available online. And that's the world over. So consumers in the Caribbean have been educated on what quality healthcare is. Yet we've not advanced the healthcare delivery system to the extent that that type of quality could be measured. Methods of payments for healthcare have not evolved in our region, and the laws that govern healthcare financing have stagnated because healthcare policymakers have not really addressed those issues. Certainly, there are some outside influence to keep the model as it currently is, but we know clearly this whole issue of healthcare financing is not working if we want to ensure or cover a population. If you look at the Caribbean, between 5 and say 15% of the population in most nations have some form of healthcare coverage, at least from the private sector. The Bahamas, the Cayman Islands, and the BVI are certainly exceptions. Now, there are the other nations that are offering some of those services. Some of the French islands, Dutch islands have more comprehensive system, and they cover pretty much all of the population. But in the Eastern Caribbean, we are still struggling with this concept of how to cover our population. So the formation of the other concept that we are concerned about is the formation of these integrated healthcare networks that's needed to service this type of national health insurance systems. And one of the challenges we have throughout the Caribbean is that we lack this integration of healthcare providers, where we work together as a unit. We could function independently, but in the US and some other countries, those are referred to as independent provider associations, where providers contract under a common contract, even though they provide care individually, but that allows the linkage between entities so that you could parse and distribute care in a manner that could control costs. So I'm going to speak a little bit about that based on what we've tried to do in the model in Grenada. But let's focus a little bit more on some of the challenges in the Caribbean healthcare delivery system as we see it. The first issue with national health insurance and the issue with coverage or the issue with healthcare systems development has to do with having a way to pay for healthcare. And national health insurance and universal healthcare is about funding healthcare and funding it in its totality. And what models we use to ensure that funding is allocated, available, and distributed in a proper way so that it's effective in delivering the healthcare service at the point of care. Acquiring and maintaining technology becomes an issue if you don't have the appropriate financing. As you know, healthcare is growing at phenomenal rates in these days in terms of technology. Certainly some of the economic drivers that consumers are concerned about and wanting and what they're asking for. Sometimes we as healthcare policymakers and business leaders understand the need for primary care. But when you have a catastrophic healthcare condition that you could potentially lose a family member that's high cost, certainly at times those issues of prevention go out of the way and we focus on the high cost care issues. There are some philosophical constructs that we have to develop in our societies to decide where we focus on priorities. When you look at how the insurance models are structured today in the Caribbean, they're all structured on specialty care, catastrophic care. And very few insurance companies offer services in primary health care. In fact, I look at some of the policy and the benefits. They may offer 1 visit or 2 visits a year to the primary care, who are generally the gatekeepers. And they really are the ones who focus on prevention. There is not a strong motivation for insurance companies in the region participating in healthcare to focus on primary care. And therefore, that's left up to the governments. Another challenge we have is retaining professionals and specialists. The Caribbean today perhaps train more doctors per capita than any nation in the world. We have more medical schools in the region than we have elsewhere, and we train doctors for all markets: Africa, United States, Europe, Latin America. But yet, we have poorly developed healthcare system. In fact, in some cases, we have a surplus of doctors, primarily in the non-specialized areas. The ability to acquire and produce medical products. We were talking about this issue a minute ago of what happened during the pandemic. The nations that we generally rely on, organizations like the CDC and others, have not been there for us in the region. The PPEs, in fact, many countries had PPEs that were shipped to them, were absconded by the US and other countries so that we weren't able to get what we needed. We were in a bind getting PPEs for our population and testing and so forth. And that still exists in some cases. The whole idea of deciding when we should go overseas for care, and of course, it's high cost because we are purchasing those overseas care costs as individuals, not as a group. So we don't have the power of collective bargaining. And the last point is the issue of training. And after we train is providing employment. One of the things we see is that we are also trained nurses, but yet we can't keep nurses. As soon as they're trained, they get better wages, so they travel to other nations and provide services. We have a problem even in our countries in providing specialty trained nurse. So we have lots of nurses that are involved in general services, but not in specialized services like cardiac care, dialysis, and so forth. And nurses do have to specialize just as physicians do. So a little bit more about the challenges from a more administrative side. in the Caribbean healthcare delivery system. We operate in the Caribbean in silos. We are all segregated. And we've inherited this from the colonial model. That colonial model maintains separate systems. We are already small and we have a tiny population, but yet we separate ourselves. That also puts us at a significant economic disadvantage. So you separate the public from the private. It creates conflict of interests, and it also creates a situation where the persons that are seeking health care are confused. Also, it stratifies us in the society, rich from poor. It limits our ability to coordinate even within the private sector, both with the private healthcare providers and the insurance companies. Another issue is the funding mechanisms and the funding sources. Truly, most healthcare is funded by the government, and it's largely tax-based. Very small percentage of healthcare budgets come from the private sector. In fact, when you take a country, say, as big as Jamaica, that has over 3 million population, they have very limited private beds in their system. Most of their beds, and I believe someone, I don't know the exact number, someone said, in a country as large as this have less than 1,000, less than 500 beds, or private beds. Most of the beds are in public facilities. The problem of health system strengthening is largely done by the government. So you conflicted in supporting new technology, new equipment, because you have fixed budgets and there is no funding for doing healthcare system strengthening. Another issue that really poses some significant problems is the governance and administration through ministries of health. Most ministries of health are not equipped with the technical training, the technical personnel and systems to be able to manage a complex healthcare system. And so what you have are the professionals that needs to be in those systems driving the directions and the policies are not available. The benefit systems in the Caribbean is very fee-for-service, or what we have is a healthcare payment model that's benefit-centric. So when you have a benefit-centric and it's not a provider-centric and it's not a patient-centric, what you have is that you use the benefit plan, insurance companies, to restrict care. So what you try to do is to limit what you pay for. And therefore you get a confused healthcare provider system and you get a dissatisfied population because insurance companies use the benefit model to limit care and to control their profits. Clearly, this is a model that we have in the Caribbean and it's not working. Last point on this is non-standards. We have very little standard-based care. Very few facilities or systems in the Caribbean are accredited based on international standards. So for example, if you have a cardiovascular event, you have chest pains, there are models that says what happens after that if that patient has a cardiovascular issue. We don't have those models except in few nations that we follow for getting a patient to cardiac catheterization within a certain period of time, or be provided a certain medication or stent or some of those issues. So what you have is ongoing, once you have an illness, you are likely to either die from it or suffer long-term untoward outcomes. So how do you develop a national health insurance system amidst all of these issues that I've just identified and have it become sustainable? Basically, what we've seen in the entire Caribbean, in all attempts, and I'd say some exceptions, to develop national health insurance, it's really a Band-Aid model. And one of the challenges that all of these nations who have utilized this type of Band-Aid model is they achieve some degree of universality, but they have costs that's not contained. there are no predictive modeling, data sources to be able to track and look at where things are going. Policy issues, legislative issues that are not just developed once, but are ongoing and modified according to what the system needs to keep it sustainable. So on the policy side, and I applaud again the University of the West Indies for taking a lot of leadership, we need a whole body of talent in this area, in healthcare financing, research in population health, and many of the other aspects of health policy to be able to help guide these type of systems of sustainability. So we were privileged to be given the contract by the government of Grenada to facilitate and help develop the model of national health insurance. And what we decided in so doing was not to present a Band-Aid structure, but to develop a transformative model that offered this degree of sustainability. These are some of the principles that we use, that we currently apply. First one is a top-down model over a bottoms-up model of financing. What we realize, if we understand what capital is available and how we could bring all the capital that's been utilized in healthcare in the region or in Grenada under one pot, whether it's controlled by other entities, but we have all of that capital accounted for, then we have a better way of modeling the system and distributing the capital so that the bottom side of the delivery of the point of service receives what they need. This method of modeling works well in a situation where you have rapid changes in your funding sources and your economic basis. And clearly COVID-19 is a perfect example of this, where the tax base that you have in all of the countries have dwindled. And so how do you, in this type of environment, continue to implement national health insurance? Or how do you continue to sustain that model without having to fracture this model in a way that it's not sustainable? And this is not the first time this will occur. We know that this is going to be an ongoing issue. And certainly people call on government to solve those problems, but we say these are problems that are not only for governments, but it's for businesses, it's for all concerned. So the consolidation of the financing does give us the power of economies of scale so that we could respond in times of stress. Certainly, we've done this in the banking industry in the Eastern Caribbean. The issue of cost containment. How do you contain the costs and manage the rising healthcare costs by implementing models that allows you to track, monitor these changing healthcare cost models? One of the things we've seen in most of the Caribbean systems that have implemented national health insurance is that they have not included cost containment in their model and in their implementation. As a result, all of these institutions, just about all of them, are seeing tremendous cost overruns without any control mechanism in place. Another principle is that of shared risk. We've seen this being an issue. I already talked about this whole stakeholder participation from our concepts in terms of developing it, but we see an issue that if you share the risk across a population rather than a small group. So for example, the people who have insurance are generally the working class or the people who are wealthy. That's a small group. Insurance is about spreading the risk across a broader population to allow for affordability. National health insurance offers that, but you don't only spread the risk across the population, but the financiers and also the consumers of healthcare. So both for further growth and development in the healthcare system. If you have national health insurance and you have a funding mechanism, this is the way to grow and further develop your healthcare system. Clearly, restructuring the governance is another basis we use because we believe that it'll build confidence in the society that we are doing something fair, and it also would offer security that you have a sustainable system. Certainly governments change and politics drives those decisions. And we feel that we must have a neutral system that allows that, irrespective of change in government, that this type of model system does not change just because of government change. And this is an important issue. And I really must applaud the government of Grenada for giving us the ability to go in and even work with the opposition to help develop what we are talking about. Accountability from a capital allocation perspective. This is important also to keep the system fair and to avoid conflict of interest, and that's a part of sustainability. Modern information technology and efficient administration. Today, the administration of healthcare is fragmented at all levels. Each entity is doing their own administration in a silo. And therefore, not having a modern information system that links everybody together, that consolidates the data in one place, makes it very expensive. 20 to 30% of healthcare, the healthcare dollar goes into administration in the Caribbean. It should be less than 12 to 15%. Our goal in Grenada is to bring it to somewhere between 8 and 10%. That's the admin cost. And we're doing this through consolidation. We want to promote, as a major part of our initiative, and I know the earlier speakers talked about this whole concept of private-public partnership. While we depend on government, we also want to reduce our reliance on government on us because of sustainability. So when you have downturn in the economy, just as we have now, we have other sources of capitalization that will help buffer the system. This is very important. Now, when you think about stakeholders, because of the culture and the social conscience that we have, we hope, and one of the slides by Dr. Lanka in his presentation talks about risk, talks about economics, talks about contribution, and also talks about people that utilize the system. Obviously, the poor would generally utilize the healthcare system more, but they have less to contribute to it. In a national health insurance system, you are your brother's keeper. A concept that is driving this financing in Grenada is that of when we look at how we actually pay for this. Our model calls for using the current dollars that are in the system and the current dollars that consumers are spending. In Grenada, for 100,000 population, 109,000 population, they spend $90 million in out-of-pocket expense. So if you take that and you divide it for every man, woman, and child, clearly that's a premium in itself. So why not take those dollars and spread it across the population through the taxation system? So instead of a few people contributing a large amount, all persons contribute a small amount. And then take the resources that you're currently using and add that to the system. A challenge to make this fundamental change, and we believe this is the transformative issue that we face in getting through this system. There is in all healthcare systems in the region, because of the colonial model, a sense of bureaucracy. So the key winning strategy that we see to achieve this kind of financial consolidation comes from a consolidation of the healthcare providers so that they're all working together, consolidation of all the payers, including the government, the insurance industry, the employer groups, overseas coverage and so forth, individuals with travel insurance or people that live overseas and spend time in Grenada. All of those are financing sources. And of course, the patient. This, we believe, is the most powerful winning model for NHI's success. So, the solution to the challenge of timely access to care, making access affordable, and managing the non-communicable diseases that is eating up a major component of the capital is consolidation to increase the numbers of persons covered so that we could spread the risk, capitalization of the healthcare delivery system through a consolidation of capital, consolidation of all of the providers into an organization where care could be delivered and patient could receive care in an orderly fashion through an accredited, highly qualified system. Introduction of cost containment methodologies. Develop a standard care coordination model where we know where to send which patients and for what purpose, so that the patient doesn't go to the wrong place where you sort of get a kind of duplication of service. A big one for us is to consolidate the administration and utilizing the financial capital to develop healthcare system. So how is this done? We believe the whole issue in healthcare is about value. And value transcends just dollars and cents. It has to do with a social responsibility as individuals, as a government, and as a region to actually find a way to get the best value for healthcare. Here is a thought that we all should consider, right? We tend to put value in material things. And when you think of your health, not just as an asset, just like your car and your home. In the Caribbean today, you're required by law to have insurance on your car. No one would give you a loan in a bank if you don't have insurance on your house. And most of us buy a policy for our death, even to pay for a coffin, to be buried. So how about healthcare coverage? Do we value our health less than we value our homes, the coffins that we're going to pay for, and a car that we drive? That's a fundamental question that we have asked the Grenadian society to, in terms of representing this whole concept of national health insurance. So this pales in comparison to what people spend on everyday activities. So from a transformative model of consolidation, we see value-based healthcare as the basis for the national health insurance product that we develop in Grenada today. And we hope that this kind of model could be developed in the Eastern Caribbean. Value is measured by outcome over cost. So if you have a good outcome and you have low costs, you have increased value. A simple mathematical formula. How do you develop value-based healthcare? Value-based healthcare is tied to a reimbursement model that's tied to something called episodes of care. This is unheard of in the region. When you get sick and you have an episode and you go to the hospital and you get seen by multiple entities, private or public, we have to be able to cost that in a value-based proposition. So when you have doctors working in the public system and the private system, one person goes to the private system to get a CAT scan or MRI, then they come back to the public system to have surgery. We have to have a transparent system that allows patients to flow freely in that model and a standardized payment system that allows care to be delivered without this type of silo mentality. That's how value-based happens. System-based care. Take transplant. Take something like renal dialysis or cardiac care. We have to develop system-based care where we are able to provide care in an interdisciplinary team approach so that you have all of the qualified professionals working together. So you're not running across town to get the lab, and you're not going across town to get the prescription. You need a system-based care because that also lowers the cost for the persons achieving care. In some systems, the person has to miss work 3 times in a week to be able to get the prescription, see the doctor, go to the lab, go to therapy, when they could go into one building and get all the care they need. We're talking about a system of population health. So we look across the board and we say, how many people in the society has diabetes? And how effective are we in our primary healthcare system in bringing down the hemoglobin A1C of the entire population, averaging say 9 or 10. Let's bring it down to 7. That's what population health is. If you think of persons with a hemoglobin A1C of between 8, 9 and above, most of those individuals in 24 months would have a major organ failure that ends up having a catastrophic consequences. So a primary care physician, just looking at a person's diet, the hemoglobin A1C as a measure of quality and a measure of outcome could impact on that person not getting to renal dialysis or getting a heart attack. So you see, prevention is very important. So the ability to measure value based on cost and outcomes is critical in these value-based models. Another major driver that we've implemented in the Grenada model, or we've suggested, is the model of managing healthcare, or managed healthcare. Some people believe that managed healthcare means HMO, or health maintenance organization. Yes, to a large degree it does. But there are many other aspects to managed healthcare that has some extremely positive health benefits. One of those is the ability to cost contain through managing care. Managing care means the patient is referred to the right doctor, the right facility, receives the right products, that's tested. Make sure they're placed on the right drugs. They're not placed on a drug that has conflict with another drug that will cause a further complication. It means that you have people in the healthcare system that are not just physicians, but have the knowledge and ability to case manage, care coordinate. This is a whole new layer of care professionals that we don't have in the Caribbean that's absolutely necessary. The insurance companies today don't have those type of service providers that are absolutely necessary. That's not available in the government system. Primary healthcare providers as a gatekeeper. Of course, this whole issue of compensation and reimbursement based on value-based principles, paying for healthcare on a per head basis, or paying it for healthcare on a per diagnosis, on a per episodes of care. None of these models are available in the Caribbean today. A key component of managed healthcare is to prevent leakage. Leakage is an important principle in sustainability for healthcare. It's very important to have this system so that you avoid leaking of dollars outside of your system. And that's where, if you have the managed care system and you have the primary care gatekeepers, that drives it. So what must we accomplish? We need a hybrid model that's consolidated through an independent provider association, working with private-public partnerships. We need a care delivery system that we could upgrade with capabilities that allows for accreditation and meeting high standards. We need to consolidate the population under what we call a covered lives under management strategy. We need to pool the risk. We have a model that we created called Stratified Pooled Risk Coverage, SPARC. And the other would be centralized administrative governance and governance, so that we could control the cost of administration. So quickly, we are concerned about the model of patient-centric and provider-centric and patient-centered healthcare in this hybrid model of care over a benefit-centric care. We're organizing the physicians into an administrative model called an independent provider association, where they have some collective bargaining capabilities, pricing models so that we could standardize the pricing across the board. We could implement referral and authorization, utilization review of our cost, and see how, whether there are excessive referrals into systems and patients are getting procedures that are inappropriate or not getting appropriate procedures. In this way, you have a focus on primary healthcare and wellness, secondary healthcare at another level, and tertiary healthcare. The model has the provider-centric model has a component in the middle that we call the administrative core, such as third-party administration, the National Healthcare System Administration, the Provider Service Administration, and on either side you have the access from a payer and then the providers. So we're coming quickly to an end here. The national health insurance model is focused on appropriately passing the legislation that matches these models. And again, we've done a tremendous amount of work on this already. The governance structure, all of those we've done working, and then the stratified pool model. I'll talk a little bit about that and then I'll close. So on the capitalization side, we believe that we have to combine capitalization to sustainability. And we've defined as the model that we've defined in this model is a stratified model of coverage where it's layered. The risk is pooled together, but it's layered, so the premiums are shared, part by the government, part by private payers, part by employers, and so forth. But we have a single administration and a single provider network throughout the entire model. And this is what it looks like. First tier is a tax-based tier that's governed by the government taxes, where all of primary care and all of the basic preventative and public health care, public health services are covered for everyone in society. And then the second tier would be more specialized care. There is where the insurance and the employer groups, some of the unions could participate in providing some premiums that could manage payments at that level. Of course, the third tier could be a catastrophic tier where reinsurance could be bought through a reinsurance company. Certainly the government could be participation in this, or could be handled by a combination of the private payers and the public system. What you have that's in this model that works is a single network of provider and a single administration. So there's reduced costs in deciding who gets paid at what time. So I'll conclude by saying raising capital and risk is about what this is about. So the benefit for developed nation is to create a predictable premium and administrative model, a benefit plans that's adjustable with actuarial data analysis, and that's adjustable to changes in the economy. The risk spread across many payers types, including government and private sector. So our pool of members are covered, central administration, central technology, focus on benefits, eligibility, stacked benefits, provider centric and care centered, providing a model of management and governance that offers security to the population, and working with a network of providers that allow for consolidation and collective bargaining. Here's a launch pad. We believe that this model is transformative, given the complexity that we see moving from a colonial system to these more modern ways of funding healthcare. It needs energy, and we see the energy as political, economic, and human capital. And clearly, in order for a healthcare system to be transformed in a place like Grenada, it has to become a national concern of all Grenadians. I'll say for the Eastern Caribbean, the same. The biggest driving force behind this, as I've said to the Prime Minister and others, is something called political will. The nations who have succeeded in developing national health insurance have their start from the leaders of those nations having the political will to drive it. That's what it'll take to develop and implement national health insurance system in the Caribbean. Thank you.
For this very informative presentation. I now take the opportunity to thank all the presenters, and we will now start the question and answer segment. The first question we have is from Lydia Elliott. And it's a question from Facebook. She's acknowledging the importance of solid waste management, and she is seeking some guidance in particular about retired persons, and how do we help them manage their health issues in the context of a universal health coverage model. The second question we have from Facebook. This question is asking, how would a universal health coverage system treat persons who are low income? In other words, persons who can't afford to pay, how would the design of that system treat a low income person? The third question is by Delicia Bonnie. Delicia is asking, can you expand on currently established collaborations that support universal health coverage in the region? We will start with those three questions, and we will move on to 3 more once the panel has addressed those. Panel, did you get those 3 questions?
Yes.
Sorry, Chairperson, can you just give us the third one again, please?
The third one, can you expand on currently established collaborations that support universal health coverage in the region? Who's going first? Would you like to take a stab, Dr. Ned?
Sure.
On the design issues?
Sure. Well, first, the issue about the design of national health insurance to cover the elderly and retired and those who are in low income situation is critical. And a current model of healthcare has the government providing that what we call the safety net for those persons who can't afford. In national health insurance, while the government provides this, the idea of consolidating the dollars available from the persons who could afford to pay with the government resources puts the entire country in a better situation. There is a kind of, among the stakeholders, a resistance from sometimes the people who have and could afford, by saying, look, we could support ourselves. Why can't the people who can't afford, why aren't they able to support themselves? Well, that's why in my original talk, when I started, I asked, are we our brother's keeper? And part of the responsibility, in my opinion, of government is to help balance this equation and legislators to help pass laws that will drive this resource allocation. Unfortunately, that has not happened in every case. And I understand that there are some governments who have been successful in doing so in the region, and I think the folks from the university could comment more on that. Now, do you want me to answer the other question also in this context, or should I have them respond to this and then I'll talk to the other ones?
You could do that. We could have Dr. Lalta do the other. Dr. Lalta, Dr. Cumberbatch, in the interest of time. So, Dr. Lalta, there was this question on whether there are established collaborations that support universal health coverage in the region.
Regional collaboration has been paramount for many years, for decades actually. Within the OECS, you certainly have the work that is being done through the health desk at the OECS Secretariat. And secondly, a major part of that is the work of the pool procurement of pharmaceuticals component. And it's not just pharmaceuticals, but it's also a range of medical supplies. So that's a collaboration which has been ongoing in the OECS countries for several years. Within CARICOM, and we can broaden from the OECS to the rest of the Caribbean, you do have what we call the Caribbean Cooperation for Health Initiative. And within that structure, you have a number of activities which have taken place. I can broaden this to consider the collaboration which took place among the Caribbean countries at CARICOM with chronic disease management. That declaration in 2007 to stop the epidemic of chronic disease, which has led to a number of initiatives in several countries, establishment of national organizations, what we see now with sugar-sweetened beverages, with tobacco, with alcohol, and a number of other products. These are all aspects of the collaboration for coverage across the Caribbean countries. And broader than that, we can look at the role of the Pan American Health Organization, the Pan American Health Organization in training, health system strengthening, laboratory strengthening, which has been taking place. Also in respect of the procurement of vaccines and other essential medication. Training, for example, in the Caribbean countries, training organized through the University of the West Indies at the medical schools. So then there are different aspects of universal health coverage that one can consider. And in each one of these dimensions, you can begin to see how regional collaboration has worked. For some of the OECS countries, one of the principal dimensions one can look at is where do they send their patients? To a very large extent from the OECS countries, for example, we send patients to Barbados, or we send them to Trinidad, or we send them to Jamaica, for example. These are critical points and critical entry points for looking at the tertiary or the specialist care aspect of how we're going to be managing our health issues. Much more can be done. Having cited these, we are aware that much more can be done, but certainly we do have the groundwork. We do have some of the political will to get some of these things done. It is transforming these into the broader comprehensive framework that we have to be working on. And that's where the OECS Secretariat, the CARICOM Secretariat, become very crucial in coordination of these.
Thank you very much, Dr. Lalta. We'll go to the next 3 questions. Next question is from Facebook as well. I imagine it is directed to Dr. Ned. And the question goes like this: how can we benefit from this healthcare system that you've described in Grenada? Another question from Facebook. Brain drain, we're doing 3 at a time, Dr. Ned. Brain drain is a problem in the health sector. How can this be rectified? And the third question in this segment is from Kellon Fletcher. How do you propose governments fund national health insurance, especially with the impact from the pandemic and expected continuing, lingering economic malaise? Those are the 3 questions. So I invite the panelists to address the 3 questions. We could start with Dr. Ned and then perhaps hear from Dr. Cumberbatch.
So I'll address the first and parts of the second and third. How do Caribbean people benefit from this system? Well, certainly what we're doing, what the University of the West Indies is doing, and what others in the region, including some of the insurance companies and the governments, we need to come to a point of collaboration where we could introduce what we call best practice. I think that if we are able to, and there are lots of other consultants and experts that we could bring to the table to solve problems. And the COVID-19 is a perfect example of what we needed to do to solve this problem. Rather than fragment and sort of do everything on our own, this is I think the real message of COVID-19 is saying to us is, how do we come together to make sense of a challenge? So I think the way that all citizens of the Eastern Caribbean and the Caribbean in general could benefit is the leadership and the stakeholders coming together in some kind of organized way to consolidate the resources we have to make them work so that we have competitive advantage. One of the biggest problems we have in the region is leakage of patients outside of our region. When this happens, every dollar that we spend actually affects our currency. And there's a huge economic issue when people go out of the territory. But at the same time, if you don't have the quality of healthcare services and your survival is necessary, then you're going to leave. So the leadership and the healthcare system must come up with some better models to be able to provide a healthcare system where we all feel comfortable with the care that we need there. The second point is the brain drain. And that really ties in well with the first point. I already alluded to the fact that we train a lot of physicians and nurses in the region, and they leave for what we call greener pastures. So we have to look at how we reimburse and fund healthcare professionals as one. Two, the training that we provide them and the opportunities for a better lifestyle. Because if you're overworked and you're underpaid, obviously, you're going to look to other opportunities. And the whole economic development of the region, I mean, when you look at the economics of the Caribbean I grew up in, it's totally different. We are not lower income countries anymore. We are at least middle income and sometimes even higher. So clearly, just in general, and I guess the docs could better speak to this. And the last point is the government-funded healthcare insurance in these economic times. The model we created, we believe, would allow a government to implement national health insurance, even in a time of downturn. Yes, we have the ability to modify the payments to the doctors, modify how much contribution the consumer makes in direct payments, how much the government makes in payments, and how much other funding sources for healthcare. And think about this. People traveling could pay something for healthcare in Grenada because they may use resources. Other countries are doing that, or in the Caribbean. There are other ways of actually funding healthcare. Someone talked about solid waste. Important that we, part of the contribution, because solid waste does contribute to health challenges. So how do we, people that actually pollute the environment or use products where we have to heavily impact an environment and affect health styles, how do we extract dollars from those, because those organizations are having financial benefit? How do we use these models or these opportunities to better fund healthcare? So I think these are the ways that we could mitigate some of the issues of downturn in the economy. The other area that we're looking at, there are a lot of developed nations who are helping countries like ours who are putting forth these kinds of initiatives that we are proposing, because they are looking for these models for their own countries. And they are willing to fund many of these initiatives. In Grenada, we are actually looking for grants, and we have already received fundings from other organizations to help us. And some of that money is free. There are loans and other opportunities there. So again, we have to get the research people and the grant writing people on the ball. So there are lots of ways that we could fund this. It's just we have to become creative, and we have to have the government and the political will of the people and the government behind us to be able to do this.
Thank you, Dr. Ned. We now
Can I make a
hear
comment?
from Dr. Cumberbatch.
Yes. Very interesting questions. I want to get at the brain drain problem a bit and talk a little bit from a different perspective. One of the issues in the Caribbean is that the morbidity and the epidemiological framework that we're working with, the profile of the Caribbean, is that essentially a lot of our healthcare issues and chronic diseases, etc., really needs the participation of the community and not necessarily participation of the doctor. Let me explain. So I just want to look at it from a different point, and I'll also get to the brain drain point. What we need in the Caribbean is for people also to taking some self-responsibility for the diabetes, the hypertension, overweight, obesity, and lack of exercise. So doctors do not give you health status. You have to work at it. The doctors can help you, the drugs can help you, but you yourself have to participate in healthy living to get the benefits, especially in the Caribbean. That is very, very important. The other point I would make about the brain drain, we live in the modern world, technology. What that means for a small island state is that your healthcare provider don't necessarily have to reside in your country. Technology allows you to access people all over the world. So if you need technological support, advice, even though people may be leaving, but you can also link in the others in systematic ways throughout the world. So yes, we would like to keep our professionals here, but there are also professionals from abroad who are linking with you online to help you solve your problems. So I just wanted to make sure that we understand that we're not in a dire situation. The other point I would talk about is the question of how do we fund in the pandemic. One of the things that the HU has done through the Caribbean is that we have been costing the present healthcare systems that we have, the amount of money being paid by the population and the governments throughout the Caribbean, and whether it's in Trinidad and Tobago, Grenada, St. Kitts, and et cetera, et cetera. And what we have found is that the amount of money that is being spent right now by the public and the private sector is sufficient to have a health insurance coverage for every single citizen, depending on what your benefit package is. So let me just make that point again. The amount of money that is being spent right now is sufficient to provide a national health insurance package of services for everybody. So it is not a question of if there is the money available in the Caribbean, the money is there. The other point I would also make is a WHO assessment that came up and is relevant to us and PAHO. The inefficiencies in the health system is recognized to be around between 20 and 40%. So what that means is this, and this is for a global figure in all over the world, 20 to 40% of their expenditure in healthcare systems are being done inefficiently. So one of the key things you need to do is to look at measures to drive efficiencies. And one way of doing that is by using modern information technology. So there are savings to be made if we restructure and reorganize using modern information systems to get better outcomes, given the present value of dollars that we are spending. So this is not beyond us. The last point I would make about the cost, what we know in the Caribbean for our epidemiological profile, primary care prevention is a big winner. What we need to stop doing in the Caribbean is spending money at the end of the healthcare cycle in hospitals where people are going with severe morbidity and ending up with high mortality figures. Diabetes, hypertension, these things are preventable. So if we front load the system by making sure our primary care systems are modernized, running up to date, and universal, we will not have to spend that amount of money in the back end of the system, which does not give you a good outcome. Doing dialysis, changing your kidney, changing your coronary blood vessel, changing your joints, that's not the way to do it, you know. We need to stop the morbidity and mortality from occurring, which can be done, especially in a place like the Caribbean, where 24/7, 365, we have good weather, we have food that we can grow and eat, we can exercise. So I just wanted to make that point to look at it from a different perspective. Thank you.
Thank you, Dr. Cumberbatch. We have one more question from Facebook. Given the small population of our states, are there any specific challenges which can be anticipated from the implementation of national health insurance? I would also like the panel to speak to measures that can be aimed at driving efficiency of the system. Dr. Cumberbatch just spoke about that, and maybe a little expansion might be necessary. These will be the two final questions for the session, as it is already 12. So we'd like to get some feedback from all the panelists, as well as some summary, some closing statements. We could begin with Dr. Lalta this time.
Thank you very much, Chairperson. Two specific questions. Let me deal with the first one, or probably to continue with the discussion started by Dr. Cumberbatch on the efficiencies. Some of the big areas for efficiency savings that we can look at in the Caribbean pertain to how we manage overseas care. Where do we send patients to? How do they get there? What are the protocols? How did we negotiate for the care that is being provided? Is there a way that the OECS countries, for example, can pool their overseas care requirements? So then just as how you're pooling medications through the PPS, can we do this also and get the economies of scale from this? Certainly sending people to the US, to Dominican Republic, Panama, Cuba, for example, there are savings which can come from pooling those overseas care needs. Sharing services. Does it mean that every hospital we build in every country must have the full range of facilities? Can we, as Dr. Cumberbatch said, invest in telemedicine? Can we have moving health professionals and specialists throughout the OECS countries, rather than each country having to have its entire team of specialists? So sharing services like this become a very important part. The whole matter of length of stay, for example, in hospitals. If you do not have adequate protocols, then certainly what you're going to find altogether is that people spend a longer time in hospitals than they should be there. Let's look very closely at what is causing long length of stay compared to what the norms should be. And related to that is the whole point which Dr. Cumberbatch has been raising about why strengthen primary care. Well, if you look at a very big chunk of persons going to hospitals, outpatient and emergency care, a large number of these can also be treated in the primary care centers. Why aren't we beefing up our primary care centers? Primary care centers are not there to only deal with antenatal care or immunization or a scrape or a cut. They're there to provide a larger range of services. So by beefing up our primary care services, then that will cut down on the expensive treatments which may be provided or necessary in emergency care and in the outpatient department. So the number of areas we can look at where efficiency savings can be considered. The first question pertaining to small size, small GDPs, for example, in relation to the particular countries. Yes, that is a consideration, but how is it that you can have a private health insurance company operating in all of our countries, and when their pool is the same number of persons we're looking at, or even much smaller pools because they pick and choose persons in the formal sector, for example? How come private health insurance companies can be there? What about a national company? And what's the advantage of regional pooling again? What's the advantage of having regional IT systems and electronic systems which can provide the claims adjudication process? All of these are factors which we need to consider. What's the advantage of having regional systems which pool the overseas care arrangements? So small is not going to be the most critical constraint when it comes to putting resources together. And already the OECS has been considering this already within CARICOM. There are considerations for the regional pooling of services for the regional health insurance. So there's possibilities that we can consider in all of this.
Dr. Cumberbatch, can we hear from you?
Nothing to add to what Stanley said there. I concur with all his statements and sentiments. I'm comfortable.
Okay.
Okay, so
Finally, Dr. Ned.
yeah, so the challenge in terms of size, as I see it, is that who does what? And one of the challenges we always have in the Caribbean from a federated standpoint is to decide, because we as Caribbean people are entrepreneurs and we all want to do it our way. And the idea of relegating a service or product to one island or the other, or one group or the other, becomes an issue. In some countries, they have something called certificate of need. And to avoid that, what they do is they look at, you have independent bodies saying you could only provide this kind of service here or there, so you regionalize it so you could consolidate. I don't know if that's possible in the region, because that's really difficult. You are free states to do what you want. But sometimes if you could collaborate, I mean, if you're gonna get an expensive technology like radiation therapy, every island can't afford it. So, could you centralize it in certain Caribbean islands where it becomes more? And then the other question is, how do you do it between the private and public? Because the public sector may have it and only have access to a certain population of patients. And then the private sector has it and they really duplicate the service, and neither one of them are have enough services to make it efficiently run. And so how do you support technicians and all of those things? So this consolidation modeling, I think, is a major challenge in the design and development of these systems. The next point I would say would be, we have a very strong colonial model throughout and I'm not against the model by any means, but when you look at how the employment situation is, healthcare, in order to prevent brain drain, you have to promote and you have to have a merit-based system rather than just a seniority-based system. So those are difficult things to do in a Caribbean context. And healthcare is much about merit because it's about the qualification, the experience, and the training of the person in treating a particular disease, not just because that person worked in the system for a long time. So you need the combination of both a seniority and a merit-based system. And that's really challenging in small-sized nations where we are families, we are close to each other, and of course, it's very difficult to maneuver around those types of issues. So I see those two issues as challenging, but if we focus on how we make a difference, they could work.
Thank you very much, Dr. Ned, for this intervention. We've come to the end of our session today. I don't know if any of the panelists have any final words. We're about to close, but if you have any burning words that you'd like to add.
Well, I'd like to say one thing, and that is I want to really congratulate your organization for putting this type of initiative together. First of all, you are a beacon and a great example of collaboration in the region. And I trust that, you all could offer a kind of leadership or continue to offer that kind of leadership in encouraging these type of collaboration that all of us have spoken about, because now with COVID-19, this is a kind of life and death situation. When you think about our countries being exposed to a condition such as this, and the only real solution we have is quarantine and closing our borders. And not that we can't treat somebody with COVID-19, but in a if we have an outbreak that's uncontrollable and we don't have access to the resources to manage patients, of course, this could become catastrophic. And the fact that, as Dr. Lanta and others have said, we've seen so much other conditions in the region with the mosquito-borne conditions and others that has contributed significantly to the problems in our nations, it's obvious that it's a wake-up call. It's time for us to really organize and do something about healthcare in the region. Thanks.
Thank you, Dr. Ned. I accept those kudos on behalf of the governor who leads and directs this institution and who has insisted that we continue this engagement during this period. Dr. Lalta, you wanted to make an intervention?
Yes, Madam Chairperson, since I started the ball rolling, I might as well stop it as we come to the close of the innings. Firstly, to thank you and your team for putting together this panel discussion on this very crucial situation that all of us are facing. I think two comments on this. Firstly is that leadership becomes very, very important. This is not going to be the death knell of the OECS countries or of the Caribbean. We've faced epidemics and pandemics before. In fact, the HIV pandemic is still in our midst. The NCDs are still in our midst. And so we are managing with these. We have to learn to adjust. Leadership becomes very important, but more and more, our cultural values pertaining to personal freedoms, civil liberties, personal responsibility. Can we build on this feeling of health is important? Can we build on this feeling in the population to now project that to other health issues, NCDs, other chronic diseases, other infectious diseases? So how do we use this empowerment situation and the opportunities for empowerment to create a much more health conscious and healthier population? That's part of Sustainable Development Goals. That's part of what universal health coverage is all about. And thirdly, while we might, want to become very pessimistic in this situation, let's look at the countries which have faced this already and seem to be making headway. What's happening to China, where it all started? In the first quarter of 2020, China's growth had fallen. Second quarter, they're up again. Third quarter, it may be up again. The country has managed the crisis and it seemed to be improving. Singapore, Hong Kong, and several other countries. Let's begin to really pick and learn the lessons of other countries which have managed this. Cuba, our neighbor very close to us. And so it is not a totally pessimistic situation. In every crisis, there are opportunities for improvement. Thanks.
Thank you. Thank you very much, Dr. Lalta. Let me thank the panelists for what I consider a very exciting and intense conversation today, very thought-provoking. You left us with a lot as policy makers to think about and to think about how we could go about supporting appropriate public policy frameworks, public health policy frameworks in the region. So I thank you very much on behalf of the Executive Committee of the Eastern Caribbean Central Bank for taking time out to participate in this exercise and for bringing us such valuable presentations and insights. I also thank the team from the research department who were responsible for putting on this webinar today and for organizing the seminar led by Chanel Thompson, the head of our technical unit, and Zana Bernard, who is here with us today. You're not seeing them, but they've been very involved in this whole process. And we also have our corporate relations department, the lifeblood of this whole public relations engagement profile. They have been very supportive and they are the ones who provide us with the necessary infrastructure and support to actually conduct this, this webinar, led by Director Shimalan Kirby. We have also Marlon, Marlon Crawford, Karina, and Shanna. Thank you very much, colleagues. And we also thank the public, the participants who have been with us on Zoom and on Facebook. We thank you for your participation. This would not have been possible without you. Thanks very much, everybody. Have a good afternoon.